So let's review some questions for infectious disease. So question 1. An 18-year-old man presents to the clinic complaining of left plantar foot pain. He says he was working in the garden yesterday and got a splinter in his heel, but was able to remove it. The physical exam reveals some streaks of redness from the heel up to the surface of the lower leg. Which of the following is the most appropriate antibiotic for this patient while awaiting culture? Penicillin, azithromycin, cloxacillin, doxycycline, or gentamicin. So whenever you're approaching these questions, you should first be thinking what is the most appropriate, or what is the most likely pathogen, and also if there's any pathogens that may be life-threatening, you'd want to cover those. Okay, and the answer is A, penicillin. So the real clue here should be the streaks of redness from the wound site, and that's a sign that there's been infection of the lymph channels. So that's usually streptococcus. So this is not a staph infection here, so we don't need to prescribe an anti-staph drug. So penicillin would be appropriate. A staphylococcus infection would be like impetigo. Okay. A 24-year-old kindergarten teacher with no significant medical history develops a fever and pruritic rash over her chest, neck, and face. Physical exam shows macules and papules in various stages of development. 1 week later, she develops a cough. Chest x-ray shows bilateral infiltrates. Which of the following is the most likely diagnosis? A, pneumonia due to streptococcus, B, pneumonia due to mycoplasma, C, pneumonia due to pneumocystis jirovecii, D, pneumonia due to varicella, or E, pneumonia due to histoplasma. Alright, and the answer here is D, pneumonia due to varicella. So you can get pneumonia from varicella, and that's likely in this patient because she has symptoms of chickenpox, and she's also around children who are, frankly, vectors of chickenpox. And generally, we don't treat chickenpox with medication. We usually just let it run its course. But one of the complications of varicella, which is chickenpox, is pneumonia. So when a patient does go on to develop pneumonia, if they do, which is rare, then we actually do treat it. But pneumonia can be a complication of varicella. It's rare, but it can happen. And when it does happen, it'll be bilateral infiltrates. Okay, so here's our same patient. We've diagnosed her with varicella pneumonia. Which of the following is the most appropriate therapy in the management of this patient? A, ganciclovir, B, valganciclovir, C, acyclovir, D, foscarnet, or E, ribavirin. And the answer is C, acyclovir. So acyclovir is the go-to drug for any kind of herpes viruses. So varicella is a herpes virus. So that would be like your regular herpes zoster, chickenpox, oral herpes, genital herpes, and so forth. Ganciclovir and valganciclovir are secondary drugs, or there are primary drugs for CMV. Foscarnet is a sort of second-line drug for CMV. It's a little bit more broad spectrum. And then ribavirin has various applications, particularly in hepatitis C. Okay, 46-year-old woman has just returned home from a 3-week missionary trip in Mexico. She presents to the ED because of diarrhea, nausea, and abdominal pain over the past 2 days. Her blood pressure is 124/83, heart rate is 93, respiration is 13, temperature is 97.4. Fecal sample shows no macroscopic blood, negative lactoferrin, negative fecal fat, and negative ovum parasites. Which of the following is the most likely pathogen? Is it A. Clostridium perfringens, B. Escherichia coli, C. Bacillus cereus, D. rotavirus, or E. Staphylococcus aureus? So in any patient like this, you're always going to check vitals because she's had diarrhea, so you want to look for fluid depletion, because that is something that we would treat right away with a normal or with a bolus of normal saline. In this case, she's vitally stable. So we want to know what the most likely pathogen is and whether or not we need to treat her, which we probably won't. So what is the most likely pathogen in this patient? The answer is B, E. coli. So this woman has just got back from Mexico. I probably should have specified how long ago it was, but anywhere in Central America, in the tropics, the number one cause of acquired diarrhea for travelers there, the traveler's diarrhea, is E. coli. And that's a fecal to oral route. So it comes from contaminated water. That's the reason why you don't drink the tap water when you go to those tropical countries. You drink bottled water. And not getting E. coli is the reason. So Clostridium perfringens is usually acquired from meat. Bacillus cereus is from recooked fried rice. Rotavirus is the number one cause of diarrhea in children. And Staphylococcus aureus is usually from left-out cream sauces and milk. So enterotoxigenic E. coli is the most common cause of traveler's diarrhea. Now, E. coli can also cause a hemorrhagic diarrhea. That would be EHEC, enterohemorrhagic E. coli. That would require therapy because it's hemorrhagic. And in that case, that's not traveler's diarrhea. So this is ETEC. Okay, excuse my allergies today. And the treatment here would just be generous hydration. So I like to recommend Gatorade because it's superior to water because you're replacing electrolytes. Also, Pedialyte is good. So, that's fine for adults too. You don't have to be a child to drink Pedialyte. As a matter of fact, I would say Pedialyte's probably superior to Gatorade because it's made by doctors for the specific disorder, diarrhea, and so forth. But, some adults don't want to drink Pedialyte. Okay, question 5. A 37-year-old man presents to the ED complaining of arthralgia, malaise, and a rash on his left abdomen. ELISA and Western blot confirm Borrelia burgdorferi. Which of the following is the most appropriate course of action for this patient? A. Admit and place on IV doxycycline. B. Admit and place on IV ceftriaxone. C. Treat as outpatient with PO doxycycline. D. Treat as outpatient with intramuscular ceftriaxone. Or E. Treat as outpatient with PO chloramphenicol. So this question is typical of the USMLE in that it's not telling you what the disease is, it's telling you the pathogen. So you have to sort of make that leap. And it's also not necessarily telling you whether you admit or treat as outpatient, and obviously not telling you what drug. So you need to know all those things. Right? Give you some time to pause. And the answer is C. Treat as outpatient with PO doxycycline. So this patient does not have any significant complications. He clearly has Lyme's disease, but other than that, he's fine. Arthralgia, malaise, and rash they all point to Lyme's disease, particularly the target rash. However, he doesn't have any significant complications that would warrant admission. So we're going to treat him with doxycycline. Doxycycline is the drug of choice for all patients with Lyme's disease, with the exception of patients under age 8, whom we would treat with amoxicillin. Okay, so this is the same patient, 37-year-old, coming in with what appears to be
Lyme's disease. It is Lyme's disease after we've done ELISA and Western blot. He was put on oral doxycycline, and now he has a fever, right-sided facial droop, and altered mental status. His wife said that he didn't finish the antibiotics because his symptoms were improving. How often do we hear that? Which of the following is the best course of action now for this patient? And the answer choices are A, admit and place on IV doxycycline, B, admit and place on IV ceftriaxone, C, admit and place on IV amoxicillin, D, treat as an outpatient with PO amoxicillin, or E, treat as an outpatient with PO doxycycline. All right, the answer to this one is B, admit and place on IV ceftriaxone. So the way we treat Lyme's disease is pretty simple when we're dealing with adults. I suppose you could make it more complicated, but for the most part, what you need to know for the test is that a patient with Lyme's disease, as long as they're not having neurologic or cardiovascular symptoms, they can be on PO doxycycline. If they begin to have more complicated symptoms, particularly neurologic symptoms, as we see here, then they're going to need to be on something stronger, something IV, and that's going to be ceftriaxone in most circumstances.
Okay, 29-year-old man is undergoing chemotherapy for acute myelogenous leukemia. He presents to the ED with fever and a headache for the last 12 hours. Blood pressure is 119/81, heart rate 112, respiration 16, temperature 100.8, Koenig and Brzezinski signs are positive, optic disc is normal, lumbar puncture is performed and consistent with bacterial meningitis. And here we drew his labs, and his white blood cell count is 1.0, hemoglobin 12.2, hematocrit 35.1, platelets 334, sodium 139, potassium 4.7, chloride 104, BUN 21, calcium 10, creatinine 0.7, glucose 112. Which of the following is the most appropriate medical management for this patient? Is it A, IV ampicillin and ceftriaxone, B, IV ampicillin and gentamicin, C, IV tigecycline, D, IV cefepime, or E, IV vancomycin and linezolid? So the 29-year-old man, he's undergoing a therapy for acute myelogenous leukemia. And the answer is D, IV cefepime. So the most important thing to take out of this question is, what is his white blood cell count? First off, you know he's undergoing chemotherapy, so you know he's going to be in an immunodeficient status. And this is reflected in his white blood cell count. Certainly his white blood cell count doesn't need to be low, but in leukemia it could be falsely high. But he's got a very low white blood cell count. And what that means is that he's immunodeficient, as we would expect with a patient with getting chemotherapy. So what you should know is, and I didn't put the differential here because it doesn't matter, but what you should know is how to figure out the absolute neutrophil count. So the absolute neutrophil count is just your total white blood cell count multiplied by your percent of neutrophils. And you could either do it white blood cell count times your amount of neutrophils, or white blood cell count times your amount of neutrophils plus your amount of bands in percentage. And you multiply that, and the normal is 3.5 to 8. Since this patient has a white blood cell count of 1.0, his absolute neutrophil count is going to be something less than that. Your absolute neutrophil count is always going to be less than your white blood cell count, because your neutrophils are a percent of your white blood cell count. Now, anytime when the white blood cell count, or when the, well, I suppose the white blood cell count, but when the absolute neutrophil count drops below 1.0, and some would even say 1.5, that implies a significant Pseudomonas risk. So a patient who has either pneumonia or meningitis or is bacteremic, you have to cover for Pseudomonas. And so we need to choose a drug that is wide spectrum, yes, but also covers for Pseudomonas. And there are some, not very few drugs, but there are a limited amount of drugs that cover for Pseudomonas. And cefepime is one of them. Ampicillin and ceftriaxone and ampicillin and gentamicin would both be good drugs if this patient were healthy, in that he had a normal white blood cell count and he wasn't undergoing chemotherapy. Those would be fine to cover empirically for the causes of meningitis. Tigecycline is a drug that covers MRSA, and vancomycin and linezolid are too. Those generally are not as used in meningitis. So IV cefepime, because it covers, cefepime has a broad range of coverage. It covers gram-positives, gram-negatives, and it covers Pseudomonas. Question 8. A 42-year-old woman presents to the clinic complaining of intermittent epigastric pain associated with eating. She says the pain comes on about 1 to 2 hours after eating. She is otherwise healthy. Physical exam is unremarkable, and she has a serology drawn, as she should. If you watch the GI section, you should know that first thing you do in any patient that's clearly got symptoms of ulcer is get a H. pylori serology, and this patient's H. pylori serology actually happens to be positive. So which of the following is the best medical therapy for this patient? Is it A, azithromycin, penicillin, and omeprazole, B, clarithromycin, amoxicillin, and omeprazole, C, azithromycin, amoxicillin, and omeprazole, D, clarithromycin, penicillin, and omeprazole, or E, metronidazole, doxycycline, and omeprazole? So how do we treat H. pylori? We have a triple therapy. We used 2 specific antibiotics and a proton pump inhibitor, which you know here is omeprazole. But what are the 2 antibiotics that we use initially? And the answer is B, clarithromycin, amoxicillin, and omeprazole. So this is the standard therapy. We put the patient on clarithromycin, amoxicillin, and omeprazole. If they don't respond to this, then we can try something else. But this is the standard therapy that we initially start out with. Okay, 31-year-old woman presents to the clinic complaining, and I should tell you, just memorize this. Just memorize this. Because this is going to come up on the test. I promise you. Okay, 31-year-old woman presents to the clinic complaining of vaginal discomfort. She says that the discomfort is persistent and not exacerbated or relieved by anything. Speculum examination reveals a fishy, odorous, gray-clear fluid pooling in the posterior fornix, as well as erythema of the vaginal introitus. Examination of the fluid reveals a pH of 5.1. Which of the following would you most likely see on microscopy of the vaginal fluid? So this sounds like a step 1 question, but you need to know this because some outskirt locations, if you're a general practitioner, you're going to have to actually do this test. You're going to have to actually look under the microscope. So what are you going to see in this patient? A, branching hyphae and yeast cells, B, clue cells, C, motile trichomonads, D, PMNs, or E, spirochetes? What are you most likely to see, I should say? Right, so the answer is clue cells. So there are 3 things that point to this. First off, she's got, well, first off, the question doesn't note a sexual history, which should be a clue. And then second, the speculum examination reveals a grayish, clearish fluid, which isn't really reliable, but it can be. It's not purulent fluid. And what's really giveaway, though, here is that it's a fishy smell. With trichomoniasis, you're going to have a putrid smell. So that fishy odor should point you towards bacterial vaginosis. No odor would point you towards a yeast infection, but in that case, you wouldn't have fluid pooling. You would have what you would normally see in any candidal infection, which would be like a curdy discharge. So Another thing that's a giveaway here is the fluid, the pH being 5.1. So normally vaginal fluid is 3.5 to 5.0. So 5.1 is elevated, and that's seen in patients with bacterial vaginosis. So the branching hyphae and yeast cells would be seen in yeast infection, Candida. Motile trichomonads would be seen in trichomoniasis. PMNs, I just threw that in there. Spirochetes would be seen in syphilis. Okay, so this is the same patient. Which of the following is the best medical therapy for this patient? Is it A, trimethoprim sulfamethoxazole, B, ceftriaxone and azithromycin, C, ceftriaxone, D, metronidazole, or E, itraconazole? Now you could just as easily on the USMLE, as a matter of fact I'd say it's more common that you would get a question that just gives you this. It doesn't lead into the fact that you got asking you what you'd see under microscopy. That's more like a step 1 question. But on step 2 and 3, they're going to assume, okay, you should know what this is. All right, now what's the best therapy for this patient? Assuming you know what this is. And since we already know it's bacterial vaginosis, you should know the answer here is going to be metronidazole. So trimethoprim sulfamethoxazole is our go-to drug for urinary tract infections, assuming the patient isn't self-allergic. Ceftriaxone and azithromycin would be in the case that the patient has gonorrhea or chlamydia, which is urethritis but can also be a cervicitis and present in a similar way. Ceftriaxone, generally, that's given for the chlamydia part, but we give ceftriaxone and azithromycin at the same time if we diagnose chlamydia or gonorrhea. Metronidazole is the correct answer here, and itraconazole would be for the yeast infection. So metronidazole is effective both for bacterial vaginosis and for trichomoniasis. So metronidazole. And that can be given either orally or in a suppository form. And normal vaginal pH is 3.5 to 5. You'll see various reference ranges on that, but 3.5 to 5 is an easy way to remember it. 46-year-old charge nurse presents to the clinic for annual PPD testing. Everybody has to get this in the U.S. every year who works in healthcare. 48 hours after the test, there is 11 millimeters of induration. And I didn't put it here, but we're assuming she has no immunodeficiencies. Chest x-ray is performed and is unremarkable. Which of the following is the best next step in the management of this patient? A, isoniazid for 6 months. B, isoniazid and rifampin for 6 months. C, isoniazid for 9 months. D, isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months. Or E, no medical treatment needed. I'll give you some time here. Pause it if you want. So anytime a patient comes back 48 hours later with a greater than, generally it's greater than 10 millimeters, but sometimes it may be greater than 5 millimeters if the, under certain conditions. Usually the USMLE will make it pretty obvious it'll be greater than 10 millimeters. 5 to 10 millimeters is generally a questionable range. The next step would be a chest x-ray. This chest x-ray was negative. And so what do we do next? Isoniazid for 9 months. So this patient has what's considered to be latent TB. We did the chest x-ray to see if the patient has active tuberculosis. Certainly she's asymptomatic, but nevertheless, you can be asymptomatic and have active TB. So we do the PPD test, and it's positive, so we know she has TB, but the question is whether it's latent or active. If it were, we did the chest x-ray, we find out that it's unremarkable, so this is latent TB, not active TB. Since it's latent TB, we're going to treat her with isoniazid for 9 months. That's the standard of therapy. If it were active TB, then we would have to treat her with the 4-drug therapy. 31-year-old man was diagnosed with HIV 4 years ago. He presents for routine laboratories and examination. It is found that his CD4 count is 445 per milliliter. Which of the following is the best combination of medical treatment for this patient? Is it A, zidovudine, stavudine, and lamivudine? B, zidovudine, efavirenz, and saquinavir? C, efavirenz, ritonavir, and adinavir? D, zidovudine, zalcitabine, and efavirenz? Or E, didanosine, efavirenz, and ritonavir? Okay, I'll let you pause. The answer here is D. So zidovudine, zalcitabine, and efavirenz. Why is this the right answer? Well, you should know offhand that for any therapy for HIV, any combination therapy, we always use at least 3 drugs. And those 3 drugs are always going to be 2 NRTIs, which are nucleoside reverse transcriptase inhibitors. And then we can use, for the 3rd drug, we can use a protease inhibitor, we can use a non-nucleoside reverse transcriptase inhibitor, or we can do a 4-drug therapy, which is 2 protease inhibitors. The reason we do this type of therapy is because if you were to give 1 drug, the HIV would quite quickly gain resistance to that drug. So remember this combination of therapies. It's either 2 NRTIs and then a protease inhibitor, or a non-nucleoside reverse transcriptase inhibitor, or 2 protease inhibitors. So when you look at the question, when you look at the answers here, you have to ask yourself, what are each of these drugs? Are they NRTIs? Are they NNRTIs? Or are they protease inhibitors? And that's going to be how you get the answer, because only one of these is an appropriate 3-drug regimen. So zidovudine, stavudine, and lamivudine are all NRTIs, so that doesn't work. Zidovudine, efavirenz, and saquinavir are 1 of each, so that doesn't work. We have to have 2 NRTIs, so that basically gets rid of B and E and C. And then A is gotten rid of because that's 3 NRTIs. We can't have that. And D is 2 NRTIs and 1 NNRTI. So this can be really difficult to remember what are the NRTIs, what are the NNRTIs, and what are the protease inhibitors. So this is the best way I can relate it to you. So the best thing to do is anything that ends... First, remember that efavirenz, it ends in a Z. Efavirenz is an NNRTI. And that's the NNRTI you can't take when you're pregnant. So efavirenz is NNRTI. Anything that ends in -ine is a reverse transcriptase inhibitor. Either an NRTI or an NNRTI. Anything that ends in -ine is a reverse transcriptase inhibitor. The ones that are the NNRTIs are nevirapine and delviridine. Everything else that ends in -ine is an NRTI. Zidovudine, abacavir, didanosine, zalcitabine, stavudine, lamivudine, and emtricitabine. Abacavir is an NRTI, but it doesn't end in -ine, so that's the one exception. The rest are the protease inhibitors, and they all end in avir. And abacavir is the only exception. So ritonavir, adinavir, nalfinavir, saquinavir, aprenavir, lopinavir, ritonavir, and atazanavir. It's a mouthful. So avir, remember ovir is oh my gosh, I have herpes, and ivir is I for influenza, avir is AIDS virus. So the protease inhibitors all end in avir except for abacavir. So that's the best way to remember it. It's tricky, but you just have to commit it to memory. Question 13. A 34-year-old G2P1 at 24 weeks of gestation presents to the ED complaining of pain on urination and frequency. This has been going on for 3 days. She denies gross hematuria. Vital signs are 98.8 Fahrenheit, respirations 14, Heart rate 83, blood pressure 103/69. Physical exam is unremarkable, including the absence of costovertebral tenderness. The course of the pregnancy has hitherto been normal. Which of the following is the best course of management in this patient? A. Admission and IV ceftriaxone. B. Admission and PO trimethoprim sulfamethoxazole. C. Admission and PO nitrofurantoin. D. Treat as outpatient with PO trimethoprim sulfamethoxazole. Or E. Treat as outpatient with PO nitrofurantoin. Okay, so let you pause it. So we've got a pregnant patient here who's got a UTI. She's got no costovertebral angle tenderness, so that pretty much limits this infection to the bladder. And she's pregnant, so that's a big deal. Anytime it tells you the patient is pregnant, you better remember that, because that's going to alter a lot in our course of therapy. The answer is E. So if this patient weren't pregnant, we'd probably say D, although either of these would be correct. Either D or E would be correct. But this patient's pregnant. And in pregnancy, we do not give trimethoprim sulfamethoxazole. Why? Because it's antifolate. And because it's antifolate, it will increase the risk of neural tube defects. So this is contraindicated in pregnancy. We give nitrofurantoin for, or some various other drugs, for urinary tract infection and pregnancy. No need to admit this patient. She's simply got an uncomplicated urinary tract infection. Complicated other than the fact she's pregnant. But we do not need to admit a UTI patient in pregnancy. Now, if she had costovertebral tenderness, then we would diagnose her with pyelonephritis, and then in that case, we would admit her, because we admit patients that are pregnant with pyelonephritis. And always remember, this is sort of an unrelated note, always remember that asymptomatic bacteriuria, so if she were to just give a urine sample and found out that she had bacteria in the urine, asymptomatic bacteriuria during pregnancy is treated as if she had a UTI. So we would give her nitrofurantoin as if she had a UTI, even though she's asymptomatic. Now, asymptomatic bacteriuria, if you're not pregnant, we don't treat that. But if you're pregnant and you have asymptomatic bacteriuria, we treat that as if you had a UTI. So nitrofurantoin. Question 14. A 7-year-old girl is brought to the clinic by her mother and stepfather complaining of vaginal itching over the past week. Patient is shy and will not answer questions. That's not uncommon in little kids. On physical exam, there are small 2 mm linear excoriations along the perianal skin and labia majora, as well as generalized erythema of the surrounding tissue. Which of the following is the best next step in the management of this patient? A. Discharge on instructions to avoid irritating soaps. B. Urethral, perianal, and cervical swabs. C. Cellophane tape test with microscopy. D. Report to child services. Or E. Dexamethasone topical cream. Alright, the answer here is C. Cellophane tape test with microscopy. So this is a patient where we are suspecting pinworm. And pinworm is rather common in young kids, and it's also a common cause of vaginal itching in little girls. And also it's a common cause of anal itching in little girls and in little boys. So this, like I said, is very common. And the 2 mm linear excoriations, these short, kind of like, almost like little cuts, sort of, those are typical of pinworm. Now, the thing I wanted to sort of stress here is that not all trauma around the vagina is necessarily sex abuse. So don't jump to that, because it can be really, 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 when you see the word stepfather in here, and then you see report to child services, and she's got vaginal itching, and the little girl is shy, that can sound like, oh, it's sex abuse. This stuff is really common, and it's not sex abuse. So don't jump to report to child services. This is pinworm, which is caused by Enterobius vermicularis, and we can easily test for this by taking some tape and swabbing around the areas that are affected, and then looking at that under a microscope, and you'd be able to see the eggs. We would then treat this with an anti-parasitic. I think I actually have this the next question, so I didn't want to say the name. Discharge on instructions to avoid irritating soaps is always a good thing to tell patients of little girls, because soaps can cause vaginal itching. Urethral, perianal, and cervical swabs aren't indicated here because that would be if we were suspecting sexual abuse, if we were suspecting if she had vaginal discharge. Report to child services would be premature and not necessary here. Dexamethasone topical cream is kind of an outlier here. Okay. So a 12-year-old boy is brought to the clinic by his mother because of 2 days of diarrhea. He complains of intermittent pain and nausea, but otherwise has no symptoms. Blood pressure 109/77, heart rate 98, respirations 14, temperature 97.4. Which of the following is the most likely pathogen causing this child's symptoms? Is it A, E. coli 0157H7, B, Salmonella, C, rotavirus, D, B. cereus, E, C. perfringens? And the answer here is C, rotavirus. Rotavirus is the most common cause of diarrhea in children. So you should commit that to memory. This patient is otherwise not ill. Intermittent pain and nausea just sort of come with diarrhea, so that's really nothing to write home about. He doesn't have any other symptoms. He's vitally stable. This kid just has diarrhea, and rotavirus is the #1 cause of diarrhea in children. E. coli 0157H7 would be a pathogenic strain of E. coli that causes diarrhea, but it also would cause hemolytic anemia, and this patient would be much more sick and he would have a fever. Salmonella would cause a bloody diarrhea. B. cereus is associated with exposure to certain foods. It's a foodborne illness, like exposure to refried or reheated fried rice. And C. perfringens is associated with exposure to uncooked meat. So B. cereus and C. perfringens are possible causes, but it's not the most likely cause. 16. A 22-year-old man presents to the clinic complaining of left-sided ear pain over the past 2 days. He has also had sinus congestion and a runny nose. He denies nausea or vomiting. Vital signs are all within normal limits. On physical exam, the left tympanic membrane is red and bulging, with some purulent material in the external canal. Which of the following is the best next step in the management and the care of this patient? A. Discharge on amoxicillin. B. Discharge on nafcillin. C. Discharge on erythromycin. D. Discharge on cephalexin. Or E. Discharge after irrigation and drainage. Okay, the answer here is A. Discharge on amoxicillin. So this is a patient with a middle ear infection, and it seems that there's a little bit of the purulent material can either be confused as cerumen, or it can be a little bit of secretion from the middle canal. So either way, we're going to treat this patient with amoxicillin. That's a drug of choice for ear infections, because the causative agent for ear infection is Streptococcus pyogenes. We could also use penicillin, but that's not a choice here. Nafcillin would be given for staph diseases. Erythromycin could be given for patients that are allergic to penicillin drugs like amoxicillin, although I would use azithromycin personally. Cephalexin, I suppose, could be used as well as an alternative if you were allergic to amoxicillin. And then discharge after irrigation and drainage, that would be something if the patient had excess amounts of cerumen and was interfering with their hearing. Okay, a 52-year-old man presents to the clinic complaining of pruritus of his feet over the past few weeks. His medical history is significant for hypertension and type 2 diabetes mellitus. Vital signs are within normal limits. Physical exam reveals erythematous scaling on both feet with some ulcerations on the scaling between the toes. Tibial pulses are easily palpable. Which of the following is the best medical management in the care of this patient? A. PO itraconazole, B. PO amphotericin B, C. Topical clotrimazole, D. Topical dexamethasone, or E. PO amoxicillin. And the answer here is C. Topical clotrimazole. So this is a patient with athlete's foot, tinea pedis, and tinea pedis can be treated topically. Itraconazole would be, any oral therapy for athlete's foot would be unnecessary. Amphotericin B would be particularly unnecessary because of the side effects. Topical dexamethasone would not treat the fungus, and amoxicillin is an antibiotic. Now, anytime you have a patient with foot symptoms and diabetes mellitus, you should always be concerned about diabetic neuropathy. And one of the ways that you can sort of assess whether this patient's got good quote-unquote foot health is to check the tibial pulses, because that's showing how much circulation's getting down to the foot, and that's a good indicator of the patient's foot health, because that can be a complicator in diabetes mellitus. So the tibial pulses are easily palpable, and most patients with diabetes have relatively good foot health, but some don't. So that's something you want to check for. So this is clearly athlete's foot, and the way you can sort of distinguish that is that this is rather acute, and that there's scaling. And scaling is more typical of fungal infections. And then the ulcerations are common. Of course, anytime you've got skin disease, the skin dries out, and so ulcerations are possible, regardless of the cause. So we're going to use topical clotrimazole here. 67-year-old woman presents to the clinic complaining of yellow color under her nails that she only just noticed after she stopped painting her toenails. She has a medical history significant for hypertension and 20-pack year smoking history, which she quit 10 years ago. On physical exam, there is yellow-white discoloration beneath the toenail bed. The feet are otherwise unremarkable. Which of the following is the best next step in the care of this patient? A. PO terbinafine, PO amphotericin B, C. Topical clotrimazole, D. IV micafungin, or E. Biopsy of the nail. Pause it here again. The answer is PO terbinafine. So this is a patient with onychomycosis, and onychomycosis is a fungal infection underneath the nail bed. So because it's underneath the nail bed, you're not going to be able to get to it with any kind of topical therapy. So that's going to eliminate topical clotrimazole. Amphotericin B is reserved for severe infections. So anytime in onychomycosis, and unless the patient has a severe illness that's refractory to other antifungals, we're going to get rid of amphotericin B. IV micafungin is sort of our second line antifungal that's again sort of reserved for more severe fungal diseases. And then since this is clear onychomycosis, we don't need to do a biopsy of the nail. We'll give the patient PO terbinafine. If she doesn't respond, then perhaps we can get some kind of biopsy. But PO terbinafine would be the first drug, the first step in the management of this patient. A 19-year-old man presents to the clinic complaining of mild dysuria and urethral discharge. He has had 3 heterosexual and 2 homosexual encounters over the past year and does not remember how many were with the use of protection. He denies other symptoms. Physical exam of the external genitalia is unremarkable, and a clear discharge is easily expressed from the urethra. Laboratory results are positive for chlamydia. Which of the following is the most appropriate medical therapy in the care of this patient? A. Ceftriaxone, B. Azithromycin, C. Ceftriaxone and azithromycin, D. Penicillin, or E. Doxycycline. And this one should be drilled in your head hard, because this will come up on the USMLE, it will come up in real life, you've got to know this. C. Ceftriaxone and azithromycin. Yes, he was only positive for chlamydia, assuming negative for gonorrhea, but we're going to treat him for both, because he could be even, I suppose, if it came back negative for gonorrhea, there is an argument for only treating him with azithromycin. But standard medical practice, if you come up with chlamydia alone or gonorrhea alone, the most appropriate therapy is ceftriaxone and azithromycin. We treat for both. So, ceftriaxone and azithromycin. Anytime you're positive for one or the other, we treat for both. Penicillin would be used for syphilis. Doxycycline is used for the rarer STDs. Question 20. A 32-year-old man presents to the clinic complaining of nausea and vomiting. That should say vomiting, not vomiting. And abdominal pain. He says it has been going on for the last 2 weeks and has been gradually worsening. Vital signs are within normal limits. Physical exam reveals mild tenderness in the right upper quadrant and slight hepatomegaly. Routine labs show elevated liver enzymes. Hepatitis panel is as follows. Hepatitis B surface antigens negative. Anti-hepatitis B surface antigens negative. Anti-hepatitis B core antibody IgM is negative. Anti-hepatitis B core antibody IgG is negative. Hepatitis C virus DNA is positive, and anti-hepatitis C virus antibody is negative. Which of the following is the best next step in the management of this patient? Is it A. Zidovudine and follow-up after 6 months, B. Ribavirin and pegasylated interferon 2-alpha and follow-up after 6 months, C. Interferon 2-alpha and follow-up after 6 months, D. Entecavir and interferon 2-alpha and follow-up after 6 months, or E. Lamivudine and interferon 2-alpha and follow-up after 6 months. So sort of the way we diagnosed this patient was that he's got abdominal pain and vomiting, and it's been of the chronic sort of variety because it's been going on for a couple weeks and it's been getting worse. Physical exam showed the right upper quadrant pain, which is usually liver or gallbladder. He's got the hepatomegaly, which leads us to decide to get labs. We have elevated liver enzymes. Now with all of this, we're thinking, and then in addition to the history, which isn't included here, we're thinking possible hepatitis, so we get a hepatitis panel, which would test for hepatitis A, B, and C. Okay, so what do we do for this patient? He's got positive hepatitis C DNA. That should never happen. Answer is B. Ribavirin, pegasylated interferon 2-alpha, and follow-up after 6 months. So, any patient with that shows up initially with acute hepatitis B or acute hepatitis C, meaning that they haven't started developing antibodies, but they have positive antigens, and the profile shows that they have not been immunized, meaning that if it's hepatitis B, they've got present surface antigens, not just antibodies. Or if it's hepatitis C, meaning that they've got positive DNA, then we've diagnosed them with acute. And so if it's in the acute time frame, then we're going to treat them to see if they can clear the virus, because approximately 70 to 90% of patients, when treated, will clear hepatitis B or hepatitis C and not go into the chronic stage, which is good because going into the chronic stage means a long, bad life. So So we want to treat this patient for the acute virus, try to get them to clear it. So zidovudine is an anti-retroviral, so we don't use that. Ribavirin and pig interferon 2-alpha is the right answer. Pig interferon, we always use an antiviral with the interferon, so that's the wrong answer. And entecavir and lamivudine are drugs that we would give in addition to the pig interferon 2-alpha if the patient were to have acute hepatitis B. So ribavirin, pig interferon 2-alpha, and follow up after 6 months to check for hepatitis C. And if he was to be negative for the hepatitis C DNA, then he would have cleared the hepatitis C and all is well. If he were to still have positive DNA, then the hepatitis C virus is still there and he's got chronic hepatitis C. And for treatment for hepatitis B, etc., you can go back and look at the liver lectures. But these are appropriate treatments for treating acute hepatitis B to promote clearance. Alright, so a 68-year-old man presents to the ED with fever and malaise over the past week. It's been worsening over time. Presently, his vitals are stable, but he has a fever of 100.5 degrees Fahrenheit. He has a significant history of prosthetic mitral valve replacement, and for this reason, as he should, he is admitted for observation. On the first night of admission, his fever spikes to 104.3 degrees Fahrenheit, and he is delirious and with chills. Blood pressure is 115/83, heart rate's 132, respiration's 19. Blood cultures are drawn, and 1 unit of normal saline is started. Which of the following is the next best step in the management of this patient? Is it A, ampicillin and gentamicin, B, vancomycin and gentamicin, C, oxacillin and gentamicin, D, piperacillin tazobactam, or E, meropenem? Okay, so this is a patient that's got a mitral valve replacement, and so we are worried about septicemia because you can get vegetation on your mitral valve. We're also worried about clogging and things such as that. So, alright, so the answer here is going to be B, vancomycin and gentamicin. And actually, I was going to make meropenem linezolid. I'll tell you why. Okay, so in a patient who has a prosthetic mitral valve replacement, we have to give broad coverage whenever they have a fever. And the reason is because they are at risk for seeding and for colonization of that valve. So we cover prosthetic valves for MRSA. If it weren't a prosthetic valve, we wouldn't have to worry about that. But for prosthetic valves, we do have to cover for MRSA. So ampicillin and gentamicin would be a good choice, but it does not cover MRSA. Linezolid, down here, E, covers MRSA, but it doesn't cover the gram-negatives. So we have to have broad coverage, but coverage also for MRSA. Broad coverage does not... some of the things that give us broad coverage, like ampicillin and gentamicin, commonly given in hospitals as a sort of cocktail. It doesn't cover MRSA. And so we're not always worried about MRSA. So usually ampicillin and gentamicin is good. It's fine. But if we're worried about MRSA, as we should be in a patient with prosthetic mitral valve replacement, then we need to do something that covers MRSA. So linezolid covers MRSA, but it doesn't cover the gram-negatives, and that's why we use gentamicin as well. Oxacillin and gentamicin is basically the same place as ampicillin and gentamicin. Piperacillin tazobactam is definitely out. That does not cover, it covers some things, but it doesn't cover everything that we're looking for. So vancomycin and gentamicin. Vancomycin covers MRSA. And so vancomycin basically covers everything your ampicillin does plus MRSA. And so this is the best regimen of choice for a patient that's septic, that's got, or a patient that's febrile / probably bacteremic, that's got prosthetic mitral valve. Note that you get your blood cultures first before you initiate therapy, otherwise you could screw up your blood cultures. And you want to start your normal saline, even though he's not necessarily septic. You want to get that normal saline ready and going because this patient's status may worsen before the antibiotics take effect. So you want to sort of you want to kind of treat that possibility prophylactically before he third spaces, which we know is going to be a possibility. Okay, so last case. This is a real life case. So a 34-year-old businessman presents to the ED complaining of a sore on his penis. He says that the sore started when he caught his penis in the zipper of his pants. While taking history, he says that he is married and insists that he's monogamous. He has a recent travel history to New Delhi and says that he frequently travels for business. Vital signs are within normal limits. On physical exam, there appears a deep, that should say red, not read, deep red lesion on the prepuce, which is very tender, along with left-sided inguinal lymphadenopathy. Which of the following medications will most likely resolve this patient's symptoms? Is it A, ceftriaxone, B, acyclovir, C, azithromycin, D, doxycycline, or E, dexamethasone topical? Okay, and the answer here is C, azithromycin. What does this patient have? This patient has chancroid. Chancroid is rare in the U.S., and it's an STD. You can't always believe your patients, especially in sexual history. This is really tricky. When it comes to things like monogamy, you can't. You always still have to keep an open mind to those things, that they could still have STDs, either because they're having sex or because their partner is having sex on the side and they may be giving them something. So you can't take monogamy and say, oh, this patient's never going to get an STD. Secondly, travel history. Always important to get travel history, especially with any kind of thing that occurs around the pelvis. So vagina, penis, etc. So what STD does this patient have? He's got a sore on his penis and he's got left-sided inguinal lymphadenopathy. That is chancroid. Now, the choices here are ceftriaxone. Ceftriaxone would be good if the patient had gonorrhea. Acyclovir would be fine if this patient had herpes, which you might think it is if you didn't get a travel history. Azithromycin is the drug of choice for chancroid. Doxycycline would be given in a different STD. That would be a granuloma inguinale. And then that would be a less painful lesion with bilateral lymphadenopathy. And dexamethasone topical is something that you would never want to use in this case. So that is the end.